So, what are the contributing factors and what kind of correction is possible? First, treating mood disorders. Second, to change medication in case if the medication cause the dysfunction. For example, like such as a selective serotonin reuptake inhibitors. So we can switch to antidepressant that has fewer sexual adverse effects, bupropion or fluoxetine or any other. If a woman is abusing, have substance abuse problem, so she has to stop it. We have to insist on stopping or ceasing this substance abuse. Cognitive behavioral therapy targets negative self-view resulting from the illness. Including gynecologic disorders, for example. Mindfulness practicing. It's an Eastern practice that includes Buddhist meditation and focuses on non-judgmental awareness of the present moment. It helps free women from the distraction that interfere with the attention or those sexual sensations. It helps to lessen sexual dysfunction in healthy women and in women who have pelvic cancer or provoked vestibulodynia. Mindfulness-based cognitive therapy combines an adapted form of cognitive behavioral therapy with mindfulness. Some women, for example, those with history of sexual trauma or some abuse or whatever, bad sexual experiences, they might need extensive psychotherapy. Pharmacologic therapy. Pharmacologic therapy may include the use of estrogens, topical and systemic estrogens. For example, compounds with the estriol applied topically help with atrophic changes of the vulva and vagina. Tablets, gels, creams, all can be used. The low-dose systemic estrogen or estrogen with progesterone, the so-called hormone replacement therapy, can be used if women have concomitant vasomotor menopausal symptoms such as hot flushes. Another option is a selective estrogen receptor modulator or SPEMIFEN. Can be useful in the treatment of genitourinary syndrome of menopause, who cannot apply vaginal estrogen therapy, for example. Androgens. Androgens in therapy of female sexual dysfunction also can play quite significant role, especially in postmenopausal women with the hypoactive sexual interest or arousal disorder. There are studies on this, and it really helps. Transdermal testosterone. Transdermal testosterone in the amount of 300 mcg daily for the time of 6 months, no more than 6 months. So it should be short usage. Of course, the testosterone levels should be monitored after 3-6 weeks after start. And of course, we should monitor the adverse effects such as acne, hirsutism, virilization. The use of DHEA, systemic use, dihydroepiandrosterone, was shown ineffective, but intravaginal DHEA preparation, the so-called prasterone or intrarosa, known in the US, that can be used topically on vulvar vagina for women, postmenopausal women with dyspareunia, and penetration disorder, genital pelvic pain or penetration disorder. So the use of androgens is still weak in terms of addressing the problem of female sexual dysfunction.